This is the case of Gretel. Gretel is a 10-year-old mixed-breed canine female spayed. She has a history of a chronic right-sided nasal discharge that recently has turned bloody. Occasionally, Gretel coughs. She is non-responsive to antibiotic therapy. On physical exam, a blood-tinged nasal discharge was confirmed from the right side. There is also no airflow coming from the right nasal passage. Airflow is normal from the left nasal passage. Gretel also has a raspy type sound when breathing. Gretel has normal heart and lung sounds and a normal abdominal palpation. All blood work was normal. Our diagnostic plan was to obtain a CT examination both pre and post contrast of the nasal passages and skull, and plus or minus CT examination of the thorax. These are pre-contrast CT images from the nasal passages of Gretel. The images on the top left are more rostrally located, while the remainder of the images move caudally. Note that there is a large soft tissue mass filling the right nasal passage, and there also is evidence of extension of the mass into the left ventral aspect of the nasal passage, as well as into the frontal sinus. Let's look a little closer at each of these images. On this image, obtained in the rostral aspect of the nasal passage, there is a large mass filling the right side with extension across the nasal septum into the left nasal passage. The pink line shows the relative position of the nasal septum, and there is clear evidence of tumor tissue crossing midline into the left nasal passage. This is seen by the pink arrow. Also note the thinning of the hard palate seen on the right side, ventral to the level of the large mass lesion within the nasal passage. On this slide, there is extension of the tumor tissue to the left side across the vomer bone and nasal septum. Also note that there is a large amount of bony destruction of the normal nasal turbinates and conchae seen in the right nasal passage. In this slide, note that there is a large amount of tumor tissue that appears to be invading into the nasopharyngeal region, as seen by the pink arrow. The blue shaded area represents the position of the olfactory bulb, and in the right ventral aspect of this area, there is not a normal delineation of bone surrounding the olfactory bulb, which is highly suggestive of invasion of the tumor into the olfactory region across the cribriform plate. Also note there is a large amount of tumor tissue and or fluid within the right frontal sinus, as well as punctate areas of bony lysis of the adjacent maxillary bone. Again, a slice obtained further caudally shows invasion of tumor tissue into the olfactory bulb with bony lysis, as well as tumor tissue also within the frontal sinus. A sagittally reconstructed image shows a large amount of tumor tissue filling the right aspect of the nasal passage, as well as a large amount of tumor tissue and or fluid within the frontal sinus. On this coronally located image, again there is a large amount of tumor tissue filling the right nasal passage, with significant leftward deviation of the vomer bone and nasal septum, as well as punctate areas of bony lysis seen caudally. A spiral CT of the thorax was also performed to rule out metastatic lung disease or lymphadenopathy. These are selected images from the spiral CT, and there is no evidence of nodular lung disease or lymphadenopathy. The mediastinal structures are normal. These are two additional images obtained further caudally within the thorax, which also show no evidence of nodular lung disease. Only normal pulmonary vessels and bronchi can be seen. The image on the right is at the level of the tracheal bifurcation, and no evidence of tracheobronchial lymphadenopathy is present. The image marked with the pink arrow shows evidence of recumbent atelectasis, which is associated with the effects of general anesthesia. The last two images are also normal and show no evidence of metastatic lung disease. Only normal pulmonary vessels and bronchi, as well as normal lung parenchyma, is seen. In summary, a large soft tissue mass was seen filling the right nasal passage, and there was large amounts of bony lysis of the vomer bone, adjacent maxillary bone, as well as invasion through the cribriform plate with involvement of the olfactory bulb. Tumor tissue is also suspect within the right frontal sinus, as well as extending into the nasopharyngeal region. There is significant leftward deviation of the nasal septum and vomer bone, as well as a small amount of tumor tissue that is invading into the ventral left aspect of the left nasal passage. The spiral CT examination of the thorax was normal. These findings are highly suggestive of a large, aggressive, destructive rhinitis that in this case was much more severe on the right. Considerations for this finding would be given to an aggressive tumor such as a nasal adenocarcinoma. Aspergillosis is also possible, but considered less likely, especially in light of the animal's age as well as the amount of bony lysis present. Nasal adenocarcinoma is the most common nasal neoplasm in dogs and is locally aggressive but rarely metastasizes to distant sites. The overall prognosis for an involved nasal adenocarcinoma such as this is considered to be poor. Nasal adenocarcinomas can be radiation sensitive, and external beam radiation therapy has been shown to slow the progression of these nasal tumors as well as help control their clinical signs. In this case, Gretel underwent palliative external beam radiation therapy to decrease the size of the mass and slow its progression, as well as control the clinical signs associated with the tumor.